Hi, thanks for joining me today. I'm Dr. Angela Mazza, and today we're going to be discussing non-surgical options for thyroid nodules, specifically radiofrequency ablation or RFA. I just want to give you a little bit of a background for those of you who don't know me. I am an integrative endocrinologist. I am triple board certified in endocrinology, diabetes, and metabolism, internal medicine, as well as anti-aging and regenerative medicine. So integrative medicine, for those of you who don't know, is really a combination between holistic or whole body wellness that looks at the root cause of conditions and traditional. I came along this path because in my career as being trained in a traditional endocrinologist, specifically for thyroid, I found that one, even though my patients with thyroid issues looked good on paper, they actually were having a lot of symptoms. And I also found we were missing a lot of persons with thyroid issues in general. So I found integrative medicine and opened my practice, Metabolic Center for Wellness. But specific to our conversation today, I took care of a lot of patients after thyroid surgery to replace their thyroid hormone. And it's not as easy as you would think it is. It's very difficult to recreate what a gland does for itself. And I became increasingly frustrated by patients who had to have thyroid surgery because of nodules that were benign, because that was their only option. And I was so excited when RFA came on the radar and was FDA approved in the United States, because I felt like this was an option for my patients other than surgery. Because even even a half of your thyroid taken out can lead to 25% chance of requiring thyroid hormone replacement long term. So let's get started. So our objectives today are: one, what are thyroid nodules? Two, what is radiofrequency ablation or RFA for thyroid nodules? Three, who's a good candidate for RFA? And finally, what should you expect from RFA? Well, first off, thyroid nodules are really, really common. I tell my patients, if we ultrasound everybody that walks down the street, 1 in 3 persons is going to show up with something sometime in their life. They are so common. And the vast majority of thyroid nodules are benign. Some of them aren't going to cause any issues. Some of them might get smaller. Less than 30% become large and become a problem. And even the nodules that we biopsy that are concerning, less than 10% come back as anything consistent with cancer, because we don't want to miss cancer. So the takeaway is thyroid nodules are really common. So what are these nodules? Well, they are masses within the thyroid. And when we look closer at them, we can classify them according to what they are. So most of them are simple and just solid nodules. They may be referred to as non-functioning because they don't make too much thyroid hormone, or cold nodules. Some are toxic, or hot. So toxic nodules are overactive nodules. They start making too much thyroid hormone on their own and they don't listen to the signals to turn off. So these are not only nodules, they are causing persons symptoms of hyperthyroidism. So those symptoms include heart racing, feeling hot, anxiety, difficulty sleeping, losing weight, all the symptoms that go along with hyperthyroidism, just because of that one little nodule working overtime. Toxic nodules, even though they're a pain, they are far away, usually benign. Then there's thyroid cysts. So thyroid cysts are really just pure fluid filled. So sometimes we can drain them, sometimes they refill, but these are just fluid filled. There's complex nodules. So complex nodules have a combination of fluid as well as solid components. So they're kind of an in-between. And then there are the nodules that we don't want to miss. Those are the ones with cancer. So that's why we biopsy to rule in or rule out cancer. We're going to talk about thyroid cancer at another time, but these are the main classifications. Okay, so the best imaging by far to look at the thyroid is the ultrasound. Ultrasound is easy. I do it every day. It gives me an idea of what's going on with the thyroid, not only in regards to anatomy, but it helps me figure out if there's underlying autoimmune thyroid issues going on. But since you probably don't look at thyroid ultrasounds on a regular basis, here's an example of a normal one. So when you look at an ultrasound, anything that's dark is either fluid filled or air filled. So you can see right in the middle here, this is a trachea. So just to orient yourself, the ultrasound sends sound waves into tissue. And based upon the density of the tissue that bounces back, the probe reads it and brings an image that we can interpret. So imagine the ultrasound is going right against the level of the neck and passing sound waves through. So we're looking from the feet up to the head. So right in the middle is the trachea. That's kind of important. And we see on either side the left lobe of the thyroid and the right lobe. We can see the density is a little bit different. Then there's the muscles of the neck, the strap muscles and the sternocleidomastoid, and then we see the structures then we see the skin surface. On either side, the thyroid is flanked by the carotid arteries. You can see part of the left one right here, as well as the jugular veins. Right along here runs the esophagus, and there are important nerves, the recurrent laryngeal nerve that runs behind the back of the thyroid. So that's the general thyroid ultrasound, and this is the normal ultrasound. Ultrasound, best way of looking at the thyroid, no radiation, easy to do. Okay, so here's an ultrasound of someone with a thyroid nodule. So we see the trachea here, and here's the left lobe of the thyroid. So here's the left carotid artery, the tissues of the neck. And here we see a nodule right here. So no real concern. It's round. I would call this heterogeneous and solid. If we had the power Doppler on, I could tell you how much vascularity is in there. This nodule was actually biopsied and it was benign. But we can use what we see on the ultrasound to give us a suspicion of cancer, just based upon what the ultrasound looks like. This is a grading system that was based off of the American College of Radiology. So if we look at the bottom here, this is a cyst. Pure cysts are always benign, so the chance of that being cancer is very low. Moving up the spectrum, so here are what we would call complex cysts. This falls in the category we call it spongiform, just because it has a little bit of a sponge appearance. So this is also very low suspicion. Low suspicion also for these heterogeneous nodules. This is a complex nodule. You see dark fluid with solid components in there. But here we get into concerns of more suspicion. So when we see nodules that are taller than wide, or have weird shapes to them, or start having what we call microcalcifications, abnormal borders, meaning they have rugged edges, this is where we start to get suspicious. And here, actually, this is a lymph node that's suspicious. So the ultrasound itself can give us, all right, an idea, should we biopsy this nodule or can we just watch it? And then there's certain guidelines based upon vascularity as well as size of the nodule. But the ultrasound gives us our first index of suspicion. But like I said, far and away, most nodules are benign. So we're going to do a few case studies. So I'll kind of give you the upfront parts and then we'll tie it up at the end. So this is Sandy. She's a 40-year-old female that came to me because of her right thyroid nodule. This was found after pregnancy, and this is really, really common. I care for a lot of women, and nodules oftentimes tend to appear on the outside or become a level of suspicion after pregnancy because your body goes through lots of changes. And probably she had a nodule before. Changes of hormones throughout pregnancy cause it to grow. But nonetheless, here's her nodule right here. She's had multiple negative biopsies, and she's been told this is the only option for you is to have your entire thyroid taken out. She doesn't like that people call attention to it. It bothers her. It's gotten a little bit larger over the years. So we did an ultrasound in the office, and her nodule was 4.91 by 3.03 by 3.61 centimeters. We usually use a guideline of, depending upon what the nodule looks like, somewhere between 1 and 1.5 centimeters to biopsy. But we also think in terms of volume, especially when we're talking about change over time. And hers came out to about 28.2 milliliters. So that's a pretty decent sized nodule. Anything more than 10 milliliters, people, depending upon where the nodule is, people can notice it. Her main reason why she came to me was she wanted to get rid of the nodule, but she wanted to save her thyroid function. Okay, so this is Steve. He's a 30-year-old male, and he came in also for a right thyroid nodule. He noted swelling in his neck for the past 5 months. He was concerned about the progressive growth of it, and he also had multiple biopsies that showed a benign cystic follicular nodule. So this is just a variety of a benign nodule. He was recommended surgery just purely due to the size of it. It really wasn't causing him any issues per se, as far as swallowing, trouble breathing, change in voice. But he was concerned that it was going to continue to grow. And he works as a pilot, so have very strict guidelines on surgery when you're dealing with the FAA. He didn't want to have time off from work, and he just really wanted to avoid surgery if at all possible. All right, so this was his ultrasound that we did in the office. So you can see it's a quite large nodule. So it will be complex. It's got cystic and fluid components, and it's a very well-defined border, and it's about 37 milliliters, so pretty large nodule. Okay. Case 3. This is Kim. She's a 36-year-old female. You couldn't really see a lot on her outward imaging, but she did have a nodule that had been slowly growing over the years in her left lobe here. Kim's concerned she's a professional singer. This nodule, even though you can't see a lot from the outside, was causing her voice to start to not have the same quality as it had over the years. She also has had negative FNA biopsies, and she also was recommended surgery. Her main concern for the surgery was, one, she'd heard about possible complications to the recurrent laryngeal nerve and possible to her voice. So she also wanted to avoid surgery as much as possible. This is her nodule right here. It's complex. It's about 13.6 milliliters. Okay, this is case 4. This is Dawn T. She's a 48-year-old female. She has thyroid nodules. She had bilateral nodules. This was originally diagnosed about 4 years ago. Over the years, she's had progressive neck discomfort where she's uncomfortable turning her neck. She noticed some trouble swallowing. She had some shortness of breath with exertion. Her husband notices that she's really struggling for air when she's sleeping at night. She's had multiple negative FNA biopsies and has been recommended a number of times to have a total thyroidectomy. Her main concern was being on thyroid hormone replacement for the rest of her life. And she had heard so many horror stories, and she wanted to save her thyroid. So here are her nodules. She had one on the right. That's mostly cystic. And we'll talk about, we did a different procedure on that one. But here's the one on the left. So this is more solid, heterogeneous. So the one on the right was only 10 milliliters. The one on the right was a bit larger. Okay, and this is our last case. This is case 5. This is Dawn B. She's a 47-year-old female who had a toxic thyroid nodule, or overactive. She was diagnosed at about 17 years of age. This nodule has caused her to, since that time, have anxiety, palpitations, difficulty sleeping. She's been on Xanax since that time. She had had an adverse reaction to methimazole in the past and didn't want to try any other medicines. She also was recommended surgery very fearful of surgery, and she wanted to save her nodule, but also feel normal again. So here's her nodule here. That's a complex nodule in the right lobe, and this is the color flow in it. So she has lots of vascularity in this nodule. Even though this nodule is only 4 milliliters, it's causing her lots of symptoms. So one question I get is, well, why can't the surgeon just remove the nodule, go in and just pluck it out and leave everything else intact? Well, that approach does make sense. But it's a lot more complicated than it is. The surgeon can't just go in it and take out the nodule. That would cause complications in the surgery, excess bleeding, as well as complications after the surgery. So usually the recommendation is going to be at least for half the thyroid or the whole thyroid. People have lots of concerns as far as drawbacks of surgery. And they make sense. They're valid concerns. There's the fear of surgery itself. It's a scary thing. I mean, having part of your body taken out. There's the anesthesia, being concerned about being put under. There's a recovery time, not having the time, being off from work, not being able to bring in income for a couple of weeks. There's a surgical scar. I mean, it's going to be there. Even the best surgeon, there's the chance of there being a scar, and there probably is going to be some sort of scar. There's a possible injury to the recurrent laryngeal nerve, like our singer, so that can cause voice impairment. That can be short-lived or permanent. There's also the possible injury to the parathyroid gland. So the parathyroid glands sit behind the thyroid and control calcium levels. So if by accident these parathyroid glands get injured, that can cause hypocalcemia. And sometimes this hypocalcemia isn't a big deal. Patients can just take some calcium every day or when they need it. But for some people, it's more severe and can cause lifelong problems. I do have a couple patients that are on disability because of permanent hypocalcemia. It's very rare, but it can happen. And then there's a possible need for lifelong thyroid hormone replacement. Like I mentioned, even partial thyroidectomy puts a person at risk for requiring thyroid hormone replacement about 25% of the time. So surgery to treat a thyroid nodule doesn't just treat the nodule. It really just takes it out of the picture and trades one problem for another. So we essentially are taking the thyroid out of the picture, and now we're left with hypothyroidism in the majority of the cases. So first off, what is radiofrequency ablation, or RFA? Well, basically, this is a procedure that involves introduction of an alternating electric current into a tissue by an electrode. Now, thyroid or RFA has been around for a really long time, and it's been used in multiple different tissues. So essentially, it involves causing ionic agitation, which in turn causes ionic friction, and that in turn results in heat production. The frictional heat that's generated in the vicinity of the electrode causes immediate tissue coagulation, so immediate tissue destruction. And the more distant tissue is ablated by a conductive or more long-term effect. So we do see long-term effects to give a general idea. This is a minimally invasive technique used for years for many reasons. So it's been used for solid tumors of the liver, lung, and used in cardiac procedures, been used for varicose veins. So it has been used for a lot of things for many years. Now, what about RFA for thyroid nodules? It seems like it's just come up on the radar, but it really hasn't. RFA was first used for the treatment of enlarged benign nodules in South Korea back in 2002. It has been since then internationally studied and proven to be a safe, effective therapy for benign thyroid nodules, or we call them autonomously, or toxic thyroid nodules, or overactive nodules. I first learned about the initial studies right around 2005 and was so excited once it came to the States, because I knew this was going to be a great treatment option for my patients. It wasn't approved in the US until about late 2018, so it's still fairly new. We started doing them in our office here in 2019, so it's been a period of time now. There's still very few, but an increasing number of providers in the US who do offer this treatment modality. So we're really trying to get the word out. So, most patients, if they're given the option, they'd prefer not having a surgery or possibly requiring medication for life following a surgery. I think that's a no-brainer. Most people would prefer not to. RFA for thyroid nodules is done in the office under local anesthesia, gives patients essentially no downtime for work or home duties while preserving the rest of their normal tissue. We actually do them on Fridays, so I recommend just resting for the weekend, and most people are good to go back to work on Monday. So it doesn't take you out of the game for very long. Essentially, the energy is applied under ultrasound guidance. It really avoids damaging any healthy tissue. So we want to preserve that healthy thyroid function. The functioning lobe is preserved, the nodule shrinks in size, and over a few months, most symptoms that are being caused by thyroid nodules, if they're compressive symptoms, go away, and we see a decrease in the visible look of the thyroid nodule. It takes a good 12 months to see the full result of any RFA procedure. So here's kind of our setup in the office. This is me using ultrasound for guidance. This is the generator. In my right hand, this is the electrode that is connected to the generator. The electrode itself has to be at a very consistent temperature, actually a really cool temperature, less than 12 degrees, because we want to keep from over ablating tissues that we don't want to. So it's a very controlled system. The patient does have grounding pads because it is a circuit, so energy in is energy out. When we look at this screen over here, this white area, this is the electrode going in. This is the nodule. This is the common carotid artery. These are the muscles of the neck. So where we see this hyperechoic or white areas, that's tissue that's being ablated. So it's not just this tissue that's going to be ablated, but more slowly conductive heat is going to destroy part of this rest of this nodule. During the procedure, most people don't feel a whole lot of anything. You might feel some popping into the nodule, but that's about it. So we use what's called a moving shot technique. So nodules have like an ellipsoid shape. So what we call the moving shot technique is a very controlled approach. So we want to avoid structures like the common carotid artery, jugular vein, but right in here is what we call the danger triad, because that's where the recurrent laryngeal nerve sits on either behind the lobe. So the goal with any procedure is we want good results, but we want to do it as safely as possible. We don't want to cause any complications. So basically, we go in through the isthmus, which is this part of the thyroid, and essentially are systematically ablating in target zone areas of the nodule. So care is taken not to go extend past the thyroid nodule, and again, not to damage any surrounding structures. So this is the generator itself. So electric current to the body does cause electric shock, but this is radiofrequency. So there's no electric shock to the nerves or the vessels. So ablation occurs generally towards the electrode tip, which is about 3 to 6 centimeters, causes excitation of the electrons, and this leads to tissue necrosis. So the RF ablation theory is the dead cells become collagen tissue and absorbed over time. So we see immediate thermal energy and more conductive tissue necrosis with time, and the body absorbs that dead tissue. Okay, so we have every day can't say every day. Since the day of FDA approval in the United States, we've had more and more data review. There was data before, but there's even more data now. So let's take a look at a few of the studies. So what is the short and long-term efficacy of benign nodules? So this was a study back in one of the earlier studies, 2013. The main aim of RFA is to decrease pressure, improve cosmetic appearance, decrease thyrotoxic symptoms and toxic nodules. And when we look at this study at 6 months, so we always look at 6 months to a year to see the full result. 51 to 92% showed this nodule volume reduction. For non-functioning nodules, most patients reported improvement in neck pressure as well as improved cosmetic appearance. And for toxic nodules, improvement in nodule value as well as functional status. One caveat when it comes to toxic nodules, it really is all dependent upon the size of the toxic nodule. Smaller toxic nodules respond better to one procedure, but larger nodules, when we're getting greater than 10 milliliters, oftentimes require more sessions. It's just toxic nodules are more difficult because they're overactive and they have a lot of vascularity. So this study looked at primarily cystic versus primarily solid nodules and which ones did better. It's a fairly large study of over 1,000 patients. They looked at 1,600 nodules that received RFA. They used a volume reduction of more than 50% as therapeutic success. And both groups, about 80%, achieved this goal after the first ablation. So RFA was effective in reducing volume of benign nodules in both groups. I like to tell my patients our goal is at least 70% reduction, depending upon the size of the nodule. And again, as safely as possible. So what about the complication rates? So this was a study in 2022, a prospective multi-institutional study out of Tulane and Hopkins. Total of 233 nodules and 233 adults were treated with RFA. Very low complication rates of 2.5%. And these complications rates were some temporary voice changes, maybe some drainage from the RFA site, and some minor skin burns. And that's pretty, that translates well to real life too. Okay. So if you're considering RFA for your thyroid nodule, what are the benefits? Well, there's lots of benefits. It's targeted treatment. So it's not trading one problem for another because it leaves the healthy thyroid tissue intact. There's no surgical scar afterwards. That's a win. This is done in the outpatient setting. Although some RFA can be done in inpatient, we do them in the outpatient setting. It's a lot more relaxing. We use local anesthesia. There's really little to no downtime for recovery. So you're not recuperating for long periods of time. There's very little risk of complications. And I have to add that with surgery in the hands of a good thyroid surgeon, your risk of complications are less, but there's still complications that aren't variables when it comes to RFA. And if you think about it, it really reduces healthcare expenses. Most people have high deductibles now. So if you went into surgery, it is going to be that expense as well. But there's the OR expense, there's the anesthesia expense, there's taking off of work expense, there's being on thyroid hormone replacement for the rest of your life, requiring lab assessment, recurrent doctor's visits. So it's again a risk versus benefit for everyone. So what are the complications with RFA for thyroid nodules? Well, these are the most common: bruising or soreness at the site. I tell my patients, you're going to be sore for a few days because we kind of beat your nodule up for a bit, but that goes away. Most tenderness is gone within a week. There's a chance of a slight skin burn where the probe was inserted. That goes away. And then possibly some temporary hoarseness. Much less common is a hematoma, so blood collection area. Brachial plexus injury. Tumor rupture is a very rare one, and it can happen any timeline afterwards, but it also does resolve. There is the possibility of failing to obtain the desired results. So it is important to have realistic goals going into the procedure, especially if you have a very large nodule. Anything more than 15 milliliters, you're running the risk of requiring more than one procedure. And then, as I mentioned, possible additional RFA treatment. So what is required of patients before an RFA? Well, there's a comprehensive evaluation like for anything. We do consultations, whether in person or via telehealth. That's one of the benefits that we've learned with telehealth is we can do a lot remotely. Lab testing. So I recommend a complete thyroid evaluation. If necessary, some coagulation testing like PT and INR. A neck ultrasound is required. So we have to know what the actual anatomy is, as well as ultrasound guided biopsy and biopsy. Well, who's a good candidate for RFA? Well, persons with cosmetically bothersome thyroid nodules. Thyroid nodules are tough when they're large, and depending upon where they're at on the neck, especially ones right in the front. People see them, it bothers them. When you look in the mirror, you see it every time. People call out attention to it, like, what's wrong with your neck? It becomes bothersome. Biopsy-proven benign nodules causing symptoms. So if the nodules causing you to have trouble swallowing, causing your voice to change, causing it difficult to sleep at night, causing it difficult to exercise. I mean, these are reasons why you probably want to think about doing something, even though it's a benign nodule. Benign nodules that no matter what size, they're growing pretty quickly and they're not causing you symptoms now, but they're growing at a progressive rate. I always say it's easier to treat these nodules when they're smaller than when they're bigger when it comes to RFA. So if you have a nodule that's changing rapidly, it's better to do it earlier than later. There's people that can't have surgery or choose not to have surgery. This is a good option for some of them. And then there's nodules that produce too much thyroid hormone. So these are those toxic nodules. Who's really not a great candidate for RFA? Well, persons with really small nodules. If they're really small, they haven't changed, I would just leave them alone because chances are they're not going to be an issue. Persons with implantable pacemakers or defibrillators. People on blood thinners or anticoagulation that can't be stopped for a procedure. So those are not good candidates. People with severe heart disease, not a good candidate. And persons who are pregnant. Okay, let's take a look at our cases again as far as follow-up. So this is Sandy. She had a 2-month follow-up. So you can see even at 2 months, we really determine at 6 to 12 months, but I do a 2 or 3 month interval evaluation because I want to make sure everything's going well. She notes a decrease in size of the nodule. She's really happy with the results. She didn't realize she was having trouble swallowing, but she actually was. And she said people aren't pointing out her nodule to her like they used to. That's a win. So her ultrasound at her follow-up went from 28 milliliters down to 8.5 milliliters. So that's a pretty significant change in just 2 months. Not all nodules will have this great result at 2 months, but this is an ideal case. So 70% post-RFA. So this is our follow-up with a pilot. This is his 6-month follow-up. He notes a decrease in the size of the nodule. He's happy with the way he looks. He's happy that he didn't have to take off work. And he's also happy that his nodule went from 37 milliliters to 3 milliliters. So that's a 92% volume reduction post-RFA. So here's our 3-month follow-up of our singer. So I always get a little nervous when we're dealing with the person's livelihood. But at 3 months, she's saying that she's noticing improvement in the strength of her voice. She's able to sing again. Her nodule was 2.26 milliliters upon return, which is a 70% decrease in volume status post-RFA. So here's her nodule right here. Okay, so this is Dawn. She's very happy with her results. She notes it's easier to swallow. She's not having trouble breathing at night, which is good. Her husband says she's not struggling for air at night, and she's noting less neck tightness. So the right nodule, if you remember, was mostly cystic. So we did do a different procedure on that called percutaneous ethanol injection. So basically that involves draining the cyst and adding in a little into that space some dehydrated alcohol that causes fibrosis down and prevents reaccumulation of the cyst fluid. So that she did really well with 98%. Now her left nodule is the one that we did RFA on. So at 4 months, she's had 90% reduction, which is a win. 98% reduction and 90% reduction. And most importantly, she doesn't have to be on thyroid hormone replacement, which was her big fear. She so kindly wrote this for me. For years, I was told I would have to remove my working thyroid to rid myself of this nodule. However, I simply could not accept removing a fully functioning part of my body only to take pills for the rest of my life. She researched an option and she found RFA. So I'm so happy to give her this result and this option. And then case 4, this was the toxic nodule follow-up. She's feeling better. She had a 95% reduction in her nodule. We see much less. This is all normal vascularity here. And she's happy about the size of a decrease in size of her nodule. But more importantly, she was so happy that her thyroid labs were completely normal now. And she's getting used to not having that constant anxiety. She's not requiring Xanax every day. She finds she's not having, she's able to accomplish tasks that filled her with agitation and anxiety before. So this is a real win. And she felt that this was the best decision of her life. And she feels amazing, which makes this all worthwhile. So here are the take-home points I'd like to leave you with. Thyroid nodules are extremely common, but some nodules can grow and then they become a problem. Not all of them, but some of them. Surgery may be the right option for some people, but it has complications, possibly, and may require lifelong thyroid hormone replacement. And thyroid hormone replacement, complete thyroid hormone replacement, is not always easy as it sounds. RFA has been proven safe and effective treatment for benign and/or toxic nodules for many people. So thank you so much for joining me today to discuss this topic that I'm passionate about. If you have any questions, here's the website. It's metabolic-center-for-wellness.com. So reach out to us. We can give you information. We also have my YouTube channel. We're on Instagram and Facebook, as well as a podcast. So thank you again for joining us. And I hope you take something away and learn something. Bye-bye.